Hi, this is Becky Wilson, and my presentation is on process innovation, ED to ECF placement. And we can make this happen. The problem of admitting patients to observation status for placement, it can be avoided if the patient, once medically cleared, can go directly to the nursing home. This could be solved by development of a fast track to ECF, which involves the cooperation of nursing homes, the registration staff, IT department, PTOT, to all work together to help us develop this fast track. This solution involves developing a preferred provider network of nursing homes that will accept our patients under certain conditions of participation, which would include being able to accept patients 7 days a week, weekends, all hours of the day. This process would result in an economic advantage for everybody. It would be faster for everybody involved, and there would be unlike any process that is in any hospital that I was able to locate. You can find out more information, more details by calling the number at the bottom of the screen. Identifying the problem, we first had to identify with management that we were noticing this problem, that there's an increasing number of patients that are coming to the ED just because they need placed in a nursing home. So management, of course, suggested we start tracking the data. We did start tracking it in June of last year, looking at the preventable admissions that couldn't be discharged because they needed ECF placement. Therefore, they required hospitalization. And also the barriers. Why couldn't we get them to a nursing home? The results showed that we average about 17 patients per month that end up being placed in observation just for the purpose of nursing home needs. We looked at the barriers. Why can't we? The big one is a new placement from home. That is the most difficult type of patient to get directly to a nursing home. A facility that's not able to increase the patient's level of care. For example, if they are in personal care, independent living, in a retirement community, and the facility said, well, we can't take them in skilled for whatever reason. We get multiple reasons. One of them is the next one. The facility doesn't accept new patients on evenings and weekends, or insurance authorization is needed, and we lack PTOT services on evenings and weekends. We have PT and OT available Monday through Friday, 8 to 4 only. And to get insurance authorization, if the patient has a Medicare Advantage plan, for example, requires a physical and occupational therapy evaluation. So the solution is to streamline the process. One is to try to keep the patient from coming to the ER in the first place, but to do that, we have to educate the ambulatory care management team, PCP offices, dialysis, home care, who's ever sending them in. Also, we need to create a trigger in Epic for a case management alert if the patient, when they're being registered, if they reside at a facility in any level of care, personal care, independent living, or if the person doing the registration knows that they are here just because they need placement, so that we're alerted right away, right when the patient comes in the door, so we have longer to work on it. And we need to work with IT to develop that trigger for registration to notify us, because the ER sees over 300 patients a day. There's no way we're going to know who all is in a retirement facility or needs nursing home placement. So the earlier we're notified, the better. And then the preferred provider network that we would develop would have alternate plans for patients that, for their own residents in personal and independent living, personal care and independent living, that they, if they don't have skilled available or they can't take them for whatever reason, to have some kind of alternative plan for them so that we don't have to admit them. And also insurance authorizations. There's no law that says that the hospital has to get the insurance authorization. It's just always been the expectation. So we need to work with our preferred providers, and they can get the authorization. If it's in a weekend, they can take the patient, they can get the off Monday. They can have their PT and OT, their physical and occupational therapy, evaluate them and get the authorization. That is one thing that needs to happen. And also scripting for the case manager, so we're all giving the same message to patients and families. Resources we need would be management support, participation in the process, the time from the IT department to develop that case management alert in Epic, which is our electronic health record program, cooperation from the skilled nursing facilities, the PCPs, ambulatory case managers, registration department, and any other external facilities that are sending people in, like the urgent cares, dialysis, that sort of thing, the home health nurses. Financial resources to implement and maintain any new software, I think that those would be minimal, probably just some manpower, and it'd be a one-time thing. The ED physician support of this new process, and the ED case manager would still coordinate the new process and measure the results. The framework for innovation, how this fits in, is that the patient's going to benefit from avoiding the cost of the observation stay, improve quality of care, and studies have showed that patients are more satisfied if we get them directly to where they want to go, which is skilled nursing. Then more beds would be available for patients that really need acute care. Treatment, medical clearance is obtained from the ED physician. Diagnosis, the need for skilled care is identified early on in the ED visit. Prevention is preventing unnecessary OBS admissions with the new process. Education, I've already gone over about educating external people, doctors, facilities that are sending patients in for placement. Research is working with PTOT to see how can we have more availability from them. And the outreach would be developing the network and assisting with the admission process, including off hours and weekends, reaching out to PCP offices. And finally, the process recap. The current process is very time consuming for us right now to try to get a person into skilled care, and it fails most of the time. We're lucky if we have 5 patients in a day. If we get 1, that's a good day. Even with education, we're still going to see patients in the ED. This will still happen, but our goal is to reduce the preventable admissions by 50% by the end of the year. And I think this will be a big success and a win-win for everyone.